So without any further delay, I'd like to introduce our first speaker, who I think no one better represents portal hypertension than Dr. Bruce Runyon, who many of you know. Without any further ado, I'd like to have Bruce come up and give the lecture.
Good morning. Dr. Hahn, did you know there are three kinds of people on this planet? Those who make things happen, those who watch things happen, and those who wonder what happened. So you and Paul and John are great at making things happen like this meeting. Congratulations on another fun meeting. And thank you for the honor to present this Telfer Reynolds lecture. I did this back in '07. So Telfer Barclay Reynolds was at USC 60 years. How many people work in the same institution 60 years? He was an intern in '44 and died in '04. He was Dame Sheila Sherlock's third fellow before there were really fellowships. Summerskill was among the top three also. He started the USC Liver Unit in 1954 with Al Redeker in charge of the liver unit, John Wesley with 100 beds, half of a hospital, and then Rancho Los Amigos. And he really lived to care for liver patients. 50 years of solo consultation at USC, was the only hepatologist at LA County General for about 50 years. And he also did 10 months a year at Rancho, and he did fluid and electrolyte rounds at USC regularly. He went to the ER every morning scouting for patients that he would handpick. He would track down the patient, ask the intern resident, do you want to offload this patient to Rancho? And of course, you know, the answer was always yes, because they had 20 admissions overnight or 30 admissions overnight. So he handpicked basically every patient who came to Rancho, unless they came from Harbor or another facility. He trained inspired hundreds of trainees and faculty. He was admired by all, won countless teaching awards, Master ACP, President of AASLD, feared by many. He would say things like, "Get your head out of the clouds." You're like, what? So he would intimidate people, but they remembered what he said. If anybody said liver function test or LFT, he would chew on their ear for 10 minutes. Really scary, and the whole audience is quaking, and nobody mentioned liver function test. Again, now we actually have a true liver function test that I'll get to. So Monday conference was really fun. He had some things in the blackboard. I got there early to have some one-on-one time with him once he got the chalkboard figured out and everything. And he told me his goal in life was to drop dead seeing a patient at LA County, which is amazing. Funny anecdote, he had a lot of visiting speakers, and Kit, his wife, would host the visiting speakers, and Pete had to go somewhere out of town for a lecture the next morning, and he got up from the table, excused himself, and went to, theoretically, the bank, but he came back rapidly and said, "Kit, where do we bank?" Because he didn't know. So Kit ran his non-hepatology life, and he was totally focused on liver patients. His nickname was Pete. Everybody called him Pete unless they didn't know him very well. I should have worn a white turtleneck just to mimic what he always did at AASLD, etc. And then Redeker was his first fellow. I talked to him every couple of months. He's from Iowa, I'm from Iowa. We reminisce about what's happening in Iowa. And I recently called him and said it was about hemochromatosis. And I said, "Al, what's the most phlebotomy you've done on a single patient before they went into maintenance?" He said, "Oh, 242. Just like that. He remembers all this stuff at 95. It's just astonishing. I call him for advice regularly. If he hasn't seen it, it probably didn't happen. So I was on a plane and in airports back a couple months 18 hours, and I went through that whole book, the abstract book, 2348, and skimming the non-portal hypertension, but taking notes on the portal hypertension and attending those sessions. So I'm an author of topics on ascites, hepatorenal, and Up to Date. I'm the editor for Complications of Cirrhosis for Up to Date, and they have full-time personnel screening all 50 liver journals and sending me preprints. Is this believable? What topic do we want to modify because of this? So it allows me to have my finger on the pulse, what's happening in complications of cirrhosis. So I'll discuss baclofen and midodrine. Science, that's why we're here. Did you watch the Breakthrough Awards? These were set up by Zuckerberg and the woman who founded 23andMe. It's funded by them. And it's nicknamed the Oscars for Scientists. It's not Nobel, but it pays amazingly well. And Peter Van Nieuwenhuizen won an award, and he said, "Science is a rock of truth in a sea of fake news." So we'll discuss the abstracts at the meeting, and news from the meeting, some background information. Portal pressure as a target awaits non-invasive measurement, unfortunately. So my topic isn't really much directed to portal pressure as a target, because I don't see portal pressures being done right. They're usually unbelievable. They don't follow Roberto Grossman's checklist of how to do it. So you get the pressure and you say, "I don't believe that," and you talk to them and they say, "Oh yeah, that's what it was." So we need non-invasive measurement. That's still not available. Mean arterial pressure we'll spend a lot of time on. That's why I have the blood pressure cuff. And home blood pressures are much better than a single clinic blood pressure. We'll discuss overused meds, underused meds, the true liver function test, perfused hepatic mass. We'll spend some time on some magical numbers, and ODTAA syndrome. What the heck is this? It's one darn thing after another. And you've seen this time and time again. We'll spend some time on that. We hope for recompensation, phrases to use, phrases not to use in hepatology, and then palliative care. Continuity of care, very important. So the really big news is terlipressin. The latest study was presented, and there was a 30% response in creatinine, twice the placebo. It halved ICU length of stay, but had 2x risk of sepsis, probably ischemia reperfusion, I would guess. So there are some downsides. Only 20% of terlipressin recipients needed RRT post-transplant. That is huge by itself. Icaria started this, and they sold to Mallinckrodt, so Mallinckrodt's pushing this. There was a satellite meeting about this. It's predicted to get FDA approval, perhaps available November next year, so stay tuned for that. So other big news, there's a new practice guideline on ascites. What's the difference between a guideline and guidance? 150 grand, that's the difference. That's what Keith Linder told me. To get a guideline, it has to go through all these other organizations, and that costs money, which I don't understand at all. Chairman of the committee is Ray Kim, who I really like. This is our statistician of the liver world. And Wong, Angeli, Ginez, Garcia-Sao, Mitra are on it. I didn't want to do a fifth iteration of this. I'm mostly retired now, and this is a torturous process. I was the first guinea pig for a practice guideline on ascites, the very first practice guideline, and they just beat me up every session. It was just terrible. And then I was on the committee, so I could beat up the next people who came in. So Ray thinks it's going to be published early 2020. Yeah, right. Mine took 2 years to get published. So that was when it was going through all these steps, ACG, et cetera, et cetera. So less big news. What about oral NAC prior to contrast CT in cirrhosis? 4 doses, 1,200 milligrams prior and day of the procedure. And it cut the contrast-induced nephropathy dramatically. Risk factors for nephropathy, high statin C, diabetes, diuretics. This is something that's coming in big time to help us differentiate the cause of azotemia in cirrhosis. Well, here's a meta-analysis of 9 randomized trials, 620 patients, of treatment post-large volume TAP, terlipressin, albumin, midodrine. And the good news here is midodrine for 3 days was superior to albumin in preventing post-TAP circulatory dysfunction. I've used midodrine in hundreds of patients, fabulous drug. We should be using more of it. I always give enough to get the mean arterial pressure greater than 82, and I go up with each dose. The highest I've used, 22.5 TID. Most patients are in the 15 range. Someone who needs 22.5 dies shortly thereafter. They're so hyperdynamic. What about anticoagulation? We never considered it in the old days. Then there was this randomized trial from Italy showing a survival advantage. Why is this? It probably prevents microcirculatory clotting in the liver and gut, is the thought. So we have new data on global coagulation. It could be normal in cirrhosis, hypo, or hyper. So here's a study. This is the abstract number, of course. Almost 3,000 patients. Warfarin hazard ratio versus no anticoagulation. Amazingly good. DOACs were better yet in reducing death or decompensation. And DOACs versus warfarin, DOACs cause less bleeding in this large study. Here's another study of apixaban for new or recent or progressive portal vein thrombosis in cirrhosis. 68 were complete. Resolution of the clot, partial resolution, and then only 18% bled. So some risk there, obviously. I have a summary coming up. So here's a retrospective study of non-cirrhotic portal vein thrombosis, which these are almost all thrombophilia patients. They have some abnormality in their coags. 58% on DOACs versus warfarin or low molecular weight heparin. 11% bled, no difference DOAC versus traditional. Here's even bigger database. No increased bleeding with anticoagulation or antiplatelet in the compensated patient. Decompensated patient, a slight increase in bleeding. Here's a retrospective study, fondaparinux versus low molecular weight heparin. Resolution of clot was better with the DOAC. So my interpretation, I've had terrible experience with warfarin, patient bleeding into a brain on 0.5 milligram 5 days a week. So these patients are incredibly prone to bleeding with a test dose of warfarin. So I avoid that like the plague. We want to make sure the clot is not malignant. If it has arterial signal on Doppler, that's a HCC in the portal vein. And we have to individualize treatment. Consider DOAC or Lovenox for a new or progressive PVT. Usually there's no time to ban varices to obliteration. That's what you'd like to do before starting some anticoagulant, but there's usually no time to do that. If you have 2 veins clotted, the pressure's higher to treat. Once they have mesenteric vein thrombosis, they're always symptomatic. They have no pain with clear liquids, and they get pain with full liquids or more. That's the characteristic history. We have to really treat this, or they may lose their gut. And what drug you pick probably depends on your formulary. So here's deep learning. There were several sections on this. CT in detecting clinically significant portal hypertension, portal pressure within 14 days, 407 patients versus controls. Area under the curve was good. Here's another prospective novel quantitation of surface nodularity. Again, this is deep learning. So this is coming on big, and I think we're going to have much more accurate CTs in the future that will tell us whether the patient has cirrhosis and portal hypertension or not. Here's a funny abstract. House officers repeat CT too soon. The patient had one last week. They get admitted, and they get another CT for no good reason. Very common, a waste of money. Triphasic CT rules out osteoporosis. I think this is big. Negative predictive value greater than 90%. So CT is looking very good, and I'll come up to a summary in a minute. So here's prospective measurement, liver and spleen stiffness by MRE. Very good correlation in predicting esophageal varices at endoscopy. And here's a 31,000 database. 51% of decompensated patients received beta blockers, but only 17% took them, which is very real. Once the patient realizes their impotence, their fatigue is due to the beta blocker, they just stop it, they don't tell anybody. And so 17% of patients given a beta blocker actually took the beta blocker. NSAIDs were given more than 10% of patients with ascites, and get this, more than 35% of patients with hepatorenal or SBP. Very scary. 50% were given opiates, for heaven's sake. 14% benzos. I avoid those drugs like the plague in cirrhosis. Here's another large database of patients admitted for cirrhosis. 51% received opiates in-house, 27% discharged on opiates. Very scary. So I tell my trainees and colleagues, avoid opiates in cirrhosis completely. Patients switch from alcohol to narcotics or alcohol to benzos. I've seen that transition many times. We don't want to start them on a down spiral, fatal down spiral due to narcotics. So medications in cirrhosis, we try to minimize them, and when I see a new patient with cirrhosis, I stop most of their meds because they're either harmful or neutral. I want to put them on the minimum meds. The liver has limited reserve if they get a new hit. So we have to weigh risk versus benefit of each of these meds. So I tell my trainees, patients, and families that there's two perks to cirrhosis. It cures hypertension, which is the most important one, and it allows patients to take more acetaminophen without liver injury. So patients with cirrhosis taking 4,000 milligram a day for 2 weeks had normal, stable liver tests, whereas 44% of normals had a blip in ALT up to 650 on 4,000. So it's the toxic metabolite that causes the trouble, and the cirrhotic liver makes the toxic metabolite more slowly. Here's a great paper by Barry Rumack on acetaminophen 35 years later. When acetaminophen is not enough, we give tramadol. We don't give any NSAIDs except a rare 81 milligram aspirin. Probably less than 1% of my patients with cirrhosis are on aspirin. They have to have more cardiovascular disease, cerebral vascular disease than liver disease for me to okay 81 milligram aspirin. Trazodone works well for insomnia. Hydroxyzine was studied in a randomized trial, shown to be positive. I just haven't had much luck with hydroxyzine. Trazodone seems to be better. It's also an antidepressant. Some patients will have a mood elevation and want more of the trazodone. Minimize narcotics, minimize benzos. And this is what I tell patients, it's not the meds that I prescribe that will help you, it's the pills that you actually take. Compliance is terrible with medications. So palliative care, this is very important. Here's a couple of papers in liver transplantation this year on palliative care. 72% of patients with cirrhosis have poor quality of life. 40% of caregivers have burnout, basically. And this is distinct from hospice, which has the 6-month lifespan. So goals of palliative care are to provide end-of-life care, alleviating physical, psychological, psychosocial, and spiritual pain associated with chronic illness. Who could disagree with that? So here's some abstracts on palliative care. This is Tarek Hassanein. I talked to him about this. He has a palliative care RN making rounds with him, and many of the patients were referred. Here's another abstract. 85% of decompensated patients died in the hospital. Who wants to die in the hospital? 70% died in the ICU. Really horrible. 60% were ventilated. 47% received dialysis. Only 31% have palliative care consult as an inpatient, only 5% as an outpatient. Here's another abstract. Less than 50% of eligible patients were referred for palliative care. So when you have palliative care, you reduce intubation, you reduce in-hospital death. Most hospitals that are greater than 300 beds have palliative care, and it can be continuity of care. To the credit of the University of New Mexico, their palliative care is superb. And it's basically continuity of care. It's like a transplant coordinator who will answer the phone or call back immediately. When the patient calls and they just get a recording, go to the ER, guess what they do? They go to the ER, which is the last place I want them to go. So why not think about palliative care? Why not refer early? And this is a way to punt the difficult conversation. These people, palliative care people, do this, difficult conversation all day, and it really doesn't bother them. That's why they went into palliative care. So they could do the difficult conversation for you if you don't want to. What about beta blockers? This is interesting from Agustin Elbios in Madrid. There's a mRNA signature predicting response to beta blockers. So when this will see the light of day remains to be seen. Retrospective study, readmission for hepatic encephalopathy. 90% of patients who ever used a beta blocker had hepatic encephalopathy versus 45% who never used a beta blocker. So cirrhosis cures hypertension. Didier Lebrecht told us beta blockers do not decrease blood pressure in cirrhosis. He told that to me, to my face, and I said, Didier, are you out of your mind? Do you see patients? And the answer was no. He stopped seeing patients for 29 years, basically. And then he was bored in retirement. One of his fellows told me this, and he went back to his own liver unit where everybody was flogging patients with beta blockers, and he blew the whistle on himself, showing that there's harm in giving beta blockers in refractory ascites. You reduce the survival dramatically with beta blockers in refractory ascites. So he was out of touch, and we'll spend some time on being in touch. So 88% were on more than 40, and 47% were on 160 a day. I've never got anywhere near 160 a day. And here's the curve. Beta blockers, terrible. Why is that? Because they reduce blood pressure. This curve looks somewhat similar. This is a great study by the DREAM team back in Barcelona. Rodez being in charge at this time. Ginez was a fellow at this time. So mean arterial pressure, you have greater than 82, you have excellent survival. Less than or equal to 82, horrible survival. So this study tells me to keep the MAP over 82, and I've been tracking this for decades and calculating on my phone, and it's really a worthwhile goal. So physicians who follow their own patients, which is unusual now, know that cirrhosis cures hypertension. Worsening hypotension is probably problematic in cirrhosis. Lebrecht was wrong. He admits he was wrong. We monitor blood pressure, and we stop propranolol or other antihypertensives when the blood pressure drops. And we ban varices. You endoscopists should be happy about this. Never underestimate the power of rubber bands. Banding is fabulous, my most fun endoscopic procedure. So we have to be the patient's advocate and stop their antihypertensives even when the cardiologist, the nephrologist doesn't care, the blood pressure is 80/60. I've seen that patient on 4 antihypertensives. So I stop all 4. They don't get a rebound hypertension. They end up needing midodrine. So we have to be the patient's advocate when the blood pressure drops, mental status change, rising creatinine, SBP, ALK-HEP. We have to stop the beta blocker. So here's a figure that Phil G., who was a fellow at UCLA with me, and we wrote a number of things. And this is his figure. Early cirrhosis, beta blockers cause cardiovascular problems, and we avoid them unless they have a cardiovascular indication. And beta blockers are indicated for primary prophylaxis and secondary prophylaxis of variceal bleeding. But how often do you see a patient with compensated cirrhosis who has large varices? Very unusual. So the number of patients who actually are in this window is vanishingly slim. So the window closes when the patient has refractory ascites, systolic under 80, MAP under 82, et cetera, et cetera. So we learn from our patients, and this is a quote: we must discard concepts that have no link with experience. That's Einstein. The true test of any proposition is how well it correlates with experimental results and produces a practical outcome. That's Benjamin Franklin. Science commits suicide when it adopts a creed, Huxley, and physicians should rely on what they see working in the real world. That's Paracelsus, 1530. So the patients do the teaching if we just pay close enough attention. Here's my favorite picture of Reynolds. He looks like a movie star in this picture. And this was one of his mantras. The patients do the teaching if we just pay close enough attention. So if someone had a good idea and they took it to the bedside, it fell flat on their face, he would say, go back to the drawing board. Your ideas doesn't work in the real world. So the patients do the teaching if we pay close enough attention. That's Osler and Reynolds. And here's my observation. The enthusiasm for an MD for beta blockers is inversely related to experience. Very real. And the authors of the beta blocker practice guidelines don't see patients. I know them all. Really scary. So what about MAP in the ICU? We need more data on how to treat patients with cirrhosis in the ICU. So if a single MAP was under 60, 43% died, whereas 7% died if it was better than that. So the U.S. practice guidance and European say 90/60 is the level where you stop the beta blocker, but that's way too low because that's a MAP of 70, and it's dangerously close to this fatal MAP. So the bulk of evidence favors statin use in cirrhosis. We heard this yesterday. Only 22 cases of DILI and 5 million users of beta blockers in 8 years, and this was kind of an autoimmune sparking of an autoimmune phenomenon. Simvastatin lowers HVPG. This is old data. There wasn't anything new about that. Very important. I've been tracking bicarb. I don't care what the bicarb is if it's not in the teens. Once it drops into the teens, patients do terrible. And here's 14 to 17 versus a higher bicarb on admission, AKI 3.6, odds ratio, hepatorenal, hepatic encephalopathy, GI bleeding. And here's a very important study from Nancy Rowe. I've been telling Ray Kim he needs to put platelet count in MELD, and I think he may do that after this abstract, because I asked him to go look at this abstract. So a platelet under 50, this was the group studied, less than 25,000, 70% mortality at 90 days versus 30% for higher platelet count. So platelet count is a liver function test in the true sense. And Gene Schiff, second generation hepatologist, told us that he has great respect for the platelet count. I think that's a very insightful statement. So this outperformed MELD sodium, and I re-advised Ray to add platelet to MELD. How simple is that? A platelet count or bicarb. So simplicity is the ultimate sophistication. That's Da Vinci. And nature loves simplicity. That's Einstein again. So machine learning was big. This was discussed yesterday. Histology and NASH. The machine learning was much better than just standard. And here's an interesting one. Bile acid profiles predict decompensation in PSC. Predicted dropout in a hepatocellular carcinoma, machine learning. Ascites was big. And predicting asymptomatic cirrhosis in patients scheduled for bariatric surgery, the machine learning was better than non-invasive markers. So machine learning, I think, is going to be big in the future. Who owns the patient? We own the patient, not the primary care, not cardiology, not nephrology. We have to be the patient's advocate. I give patients written instructions. Don't let anyone give you a drug unless I approve it. I want to basically approve procedures. This is without transplant as well as pre and post-transplant. When you transplant a patient, you marry them with no possibility of divorce. That's my philosophy. The 10 years I was in transplant. You can't learn from a patient if you transplant him and then farm him out to the referring physician. You have to follow that patient and realize that was a mistake. And I've seen so many bad actors transplanted who haunted the transplant nurses until they died. So tough. I'll have some more time on this. So try finding psych services for the poor. Couldn't get any psych services at UCLA, but a nurse came from London working with Roger Williams in the past, and she was a nurse shrink, basically, and she would see my patients whether they had money or not. So we are the psychiatrist and psychologist by default. Patients, if you send them to county mental health, they walk in the room, they see all these crazy people talking to themselves, and they wait for a few minutes and they get out because they don't want to wait 5 hours to be seen. And they probably would just get a drug rather than any counseling. So we are the psychiatrist and psychologist by default. I never signed up for that. It was just what I had to do with these patients. So physical exam is forgotten. It's not taught anymore. Even my Harvard trainees coming to Shiprock didn't know how to do a physical exam. This is a funny acronym, LGFD. What the heck does this mean? Is it lesbian gay? Is life is good? No, it looks good from doorway. Looks good from doorway. So this is very real, and I tell this to patients and family and friends, and they say, you're right. You know, the guy waved at me from the doorway and said, oh, we're going to get a blah blah on you, never laid a hand on the patient. So obesity makes it tough, but you can still feel the liver through a massive panniculus. Ultrasound to back you up is superb. We look for spiders, palmarothema, collaterals. One of the pre-chief resident from Harvard, I showed her great palmarothema. She took a picture, said, this is going to be image of the day tomorrow at Beth Israel. She said, nobody's ever seen this before, kind of stuff, because they didn't look. The first thing I do when I start to examine a patient, turn their palms over, look at their palms. Liver may be more granular. You don't feel nodules through an abdominal wall for all practical purposes unless they're malignant. The patients have taught me that the cirrhotic liver is better palpated subxiphoid than right midclavicular line. So feel subxiphoid and you'll find cirrhotic liver more commonly than right midclavicular line. You can get your own ultrasound. Butterfly's available now, $2,000, and they just reduced their monthly fee 75%. So I've had access to ultrasound for 20 years now. I really couldn't see patients without it. And trainees really like it when they feel the liver, and then I show them that's the liver with a rounded edge. They get this immediate feedback. We want home blood pressures, and we want to keep the MAP over 82. I'll spend a little more time on that. So rifaximin's overused, in my opinion. If you can't get it, you can give neomycin. I've never seen convincing nephrotoxicity from neomycin. I've seen one elderly woman who was near stone deaf, who became stone deaf on neomycin, one patient, 43 years. So neomycin is safe, in my opinion. Lactulose, I think, is overused. Patients just don't want to take it. So why not try basically Miralax, over-the-counter, harmless, and I'll spend some time on that. We have to taper stop antihypertensives, and randomized trials of compensated patients with beta blockers cause these people who don't see patients to extrapolate to all patients, including DCOMs. And we asked for stopping rules in 2014, and EU responded in 2015. The US took 2 more years, but they are saying 90 over 60s when you stop the beta blocker. I stop it when it's under or equal to 82. So 90 over 60 is way too low. As I mentioned before, less than 60, 43% ICU mortality. So what happens when the patient picks up the phone, calls in, says, go to the ER, they go to the ER, they get NSAIDs, Toradol, benzos, narcotics, and it turns out if a patient with cirrhosis gets a benzo and ends up in coma, ends up on a ventilator, 63% die. So patients put on a ventilator within 24 hours of admission with cirrhosis die in the ICU. Old data, very real. I've seen this time and time again. And Ray Kim tells us that 53% of patients with cirrhosis in the US in the ICU die. 53% mortality, cirrhosis in the ICU. Horrible. So I told my care coordinator, keep the patient out of the ER, keep the patient out of the ICU, and we were able to do that in many cases. Almost none of these patients needs an ERC, but sometimes they get it inappropriately. We don't want the pancreatic duct cannulated. They get pancreatitis. If you get pancreatitis on top of alcoholic hepatitis, which is where this is foolishly done, patients don't survive that. So MR I use rarely, a few a year, as a tiebreaker in focal lesions. CT and ultrasound are discrepant. I'll get a MR as a tiebreaker. MR is too sensitive. You see a little ditzel and you chase it and chase it and chase it, and finally after months of hand wringing and the patient pulling their hair out, you determine that's a ditzel. So having been exposed to that repeatedly, I avoid MR except in these circumstances. Very good for ruling in PSC, not perfect, and very good for differentiating NRH, nodular regenerative hyperplasia, from cirrhosis. So Claude Serlin in San Diego can differentiate NRH from cirrhosis by MR. And patients who have heart failure and ascites usually don't get cardiac cirrhosis, they get NRH. Got a call about this from one of my graduate trainees just a couple days ago. So albumin, I don't believe much of the literature. It was funded by the company that makes albumin. I believe Florence Wong's data that patients having a 5-liter tap don't need albumin. I don't believe the rest of the albumin literature. And Juan Rodés, who was in charge of the liver unit in Barcelona, told me at a dinner, face-to-face, that he didn't believe the albumin preventing renal failure and SBP. He wanted me to repeat that study. He didn't believe his own internal data. Why is that? Because it probably isn't real. So underused meds, baclofen, we want to give baclofen to reduce alcohol craving, midodrine to keep MAP over 82, and consider having the caregiver phase in Miralax and phase out lactulose, because patients will take Miralax, but they just don't want to take lactulose. It's too syrupy, causes too much gurgling, incontinence, etc. So think about that. It doesn't matter how you get the bowel movements out, doesn't matter what drug it is, 2 to 3 bowel movements a day. So here's the baclofen news flash. Most studies of drugs to reduce alcohol consumption excluded patients with liver disease. That doesn't help me much because all of my patients have liver disease. So here's a randomized trial by a hepatologist/shrink showing that baclofen reduces alcohol intake, 5 milligrams TID for 3 days and 10 TID. This is $4 a month. Why not prescribe it? It's practically free. So we start baclofen at the end of hospitalization for severe ALK-HEP when it's clear the patient will survive, and then we continue baclofen indefinitely. Here's our paper on baclofen in the setting of severe ALK-HEP in the alcohol literature. And here's a recent review that also recommends baclofen. There's been a lot of pushback because some of the studies had hepatitis C plus alcohol, and you really want someone with pure alcoholic liver disease to test this baclofen correctly. What about midodrine? We should be using more of that. Blood pressure drops as ascites becomes refractory. What happens when you have a patient with a blood pressure 80/60 and you ask the nurse to give diuretics? She says, oh no, I can't give them, the blood pressure is too low. So we would put a patient on midodrine to treat them and make the nurse happy. FDA tried to yank midodrine. They got 10,000 hits, including a hit from me saying you can't yank midodrine. So midodrine can increase blood pressure, improve response to diuretics. You can start at 7.5. You can go up with each dose. Usually the house officer see the patient once a day, and they don't see him till the next day, and they don't increase the dose. So if I'm in charge of the patient, if I'm writing the orders, I go up with each dose till we get MAP over 82. So here's a randomized trial in patients with refractory or recurrent ascites showing midodrine improves survival. How many drugs do we have in cirrhosis that improve survival? Vanishingly few. Midodrine's one of them, and I'm convinced this is a great drug, having been using it for decades. So we like home blood pressures. We write a prescription for a cuff or consider giving the patient a cuff. My chief at Shiprock has a closet full of blood pressure cuffs to give to patients who can't afford a $38 Costco cuff. We measure the height of patients. What happens when you ask a patient their height? They always give a number greater than reality. I had a patient who said he was 6'3" and he was 5'9". So I don't even ask their height. And I had to get one of these height measurement things at UCLA so I could have a believable BMI. We want continuity of care, care coordination, palliative care, variceal banding is big. So take-home messages, home blood pressures are better than single clinic blood pressure. Even these patients can get white coat hypertension, so their blood pressure in clinic probably isn't representative. I'm the one who usually stops antihypertensives, and we had a remote smart blood pressure cuff that my care coordinator could put in the home so we could monitor their blood pressure at a distance and not have them come back and forth. So when there's ascites and low blood pressure, we need to be monitoring carefully. Here's perfused hepatic mass. This is John Hafes. It took him 40 years to get FDA approval of this. I mean, how many people pursue something 40 years before they reach their goal? So he correlated this with laparoscopic liver biopsy, superb correlation function. It was approved in 2015. And this is what happened. So it's basically 100%. Platelet count is the first thing to go. INR, bilirubin, ascites develops in the 60 range, hepatorenal, SBP, maybe 50 range, and basically nobody survives under 40. So I had a couple patients, 42, 43, one died, one was transplanted. So magical numbers, MAP greater than 82 is a magical number, platelet count under 160, not 150, not 132, not 187. 160 is the data-supported number. Again, I've been tracking this for decades. This is very real. Max spleen size is 12 in normal, not 13. Most radiologists who haven't seen enough images and talk to the clinician think 13 is the maximum normal spleen size. Once you see hundreds of patients, 12.5, 12.7, with obvious cirrhosis, portal hypertension, you know 12 is a better number. So maximum PV diameter, 13 millimeters, and here's my 30, 30, 33 rule. What is this? This is alcoholic hepatitis. The patient's 30, the white count's 30, the bilirubin's 30, potassium's 3. Why is the potassium so low? There's no potassium in vodka. That's the explanation, basically. Plus a very high aldo level. So if a patient's on a 100% vodka diet for months before they crash, they come in with this profound hypokalemia. So here's one darn thing after another syndrome. Patients have cirrhosis on imaging or platelet under 160, then they develop ascites, then they get encephalopathy when you treat their ascites. Sheila Sherlock told us, keep these patients wet and wise or they'll be dry and demented. So if you prune them out, they get confused. Not demented, it's HE. So I run the elderly wet. I'd rather have a little fluid than have them falling down, hitting their head, which is very real. And then they bleed, which is the last thing. We treat all of that and hope for recompensation. So what's recompensation? Paul discussed this a little yesterday. There's almost no page space about this. I wrote a paper with a Colorado fellow, and we couldn't get it published because it basically says we should be focusing on recompensation and not transplant. And I think it was probably sent to some transplant enthusiasts who wouldn't publish it. So that remains unpublished. This occurs most impressively when there's severe inflammation. When the insult stops, inflammation's reduced, recompensation can occur. So it's due to reversal of the underlying liver disease, reversal of portal hypertension potentially, control or loss of ascites, encephalopathy, bleeding, and optimally we want all liver meds stopped once they get recompensated fully, and maybe the only med they're on is their baclofen. Most reversible causes of cirrhosis are ALK-HEP by far. And many of these, a third of these patients or more have cirrhosis underlying their ALK-HEP. Abstinence is the key. Give them baclofen. Reactivation Hep B with cirrhosis, very severe problem. And I've seen antivirals bring these patients back from the dead, basically. Coma, hepatorenal, SBP. You turn off the virus and they bounce back amazingly. And autoimmune hepatitis with cirrhosis, steroids, and then azathioprine. So these are my quotes. The liver takes a licking, keeps on ticking. Sorry, Timex. You really have to work hard to wear out your liver. Very true. Liver suffers in silence and then turns up its toes. And then here's a quote from a fellow who was seeing the liver bounce back. Kidneys don't bounce back. And he said, the liver's a champ, the kidneys are wimps in comparison. Very real. So I like to get the most mileage out of the original equipment. I say that to patients and trainees, and they scratch their heads and, oh, okay, I get it. You want me to keep my own liver? Yes. I spent/wasted a decade in transplant. I'd like that decade back, if you please. Recompensation's vastly superior, much cheaper. We have to treat the treatable, ALD, Hep B, autoimmune. Hep C, you treat it, but they don't get much recompensation. Their MELD may improve, but they don't go from hepatic hydrothorax, refractory ascites to neither of those. I haven't seen that. There's just not enough inflammation with Hep C to get a bounce back. So a personality transplant does not come with a liver transplant. And many of these patients are Machiavellian, manipulative. They'll say anything, do anything to get what they want, and then they do what they want. Phrases to use: I'm worried, long pause. I wish. And this would be, I wish I'd been involved with your care earlier. I'm hoping for a miracle too. And here's a website you may want to look at because it talks about the difficult conversation and palliative care in general. So we want to have gain framing where the patient can take, if they take better care of themselves, they can get a lot better. Phrases not to use: there's nothing else we can do. I've had so many patients tell me this. We avoid medical jargon, avoid acronyms, avoid discussion of loss of life expectancy. Once they hear you're going to die, they don't hear anything else. So care coordination benefits patients with cirrhosis, reduces costs, reduces length of stay, improves survival, and I think hepatology could benefit from a culture change. We need liver hospitalists, and we need liver-specific palliative care providers. So last slide, I have 9 seconds. Terlipressin and new practice guidance are coming. Pendulum swing to anticoagulating portal vein thrombosis. CT-MR may be a surrogate or replace biopsy, pressure, DEXA, dare I say endoscopy. If you see big varices on CT, you don't need endoscopy. We want to keep the MAP over 82. We want to give meds that work and stop meds that are harmful. Consider getting a perfused hepatic mask going at your institution. I did 100 of these at USC. Fabulous test. Magical numbers, recompensation, phrases to use, not use, and consider palliative care and continuity of care. Thank you for your attention.